Hi, I'm Dr. Raj. You know what? I think it's time for some more Beyond the Pearls. So I was thinking about questions people were asking me. What is highly tested on the internal medicine board exam and the USMLE? You know it. It's all about the heart. It's about cardiology. And they were asking me, Dr. Raj, can you talk about stress testing? And you know what? Let's do it. All right, I have a 60-year-old man is evaluated for chest pain for 4 months. I put it in bolded red. He describes the pain as sharp, located in the left chest with no radiation or associated symptoms. The pain occurs when walking 1 to 2 blocks and resolves with rest. Occasionally, the pain improves with continued walking that occurs during the evenings. He has hypertension, family history does not include cardiovascular disease, and any first-degree relatives, and his only medication is amlodipine. And what is that medication? Oh, that's right, calcium channel blocker, dihydropyridine. So on exam, patient's afebrile, his blood pressure is normal heart rate and respiratory rate, his BMI is 28, no carotid bruits were present, a normal S1 and S2 when auscultating the heart, no murmurs, the lungs are gorgeous. So, did I just do this? Did I put an EKG up there? Uh-oh. So why don't you guys hit your pause button for a little bit, stare at the EKG, and remember, go through the 5 steps. Rate, rhythm, access, intervals, and morphology. So we all stare at this because this is going to be a key part to the question. So which of the following is the most appropriate diagnostic test to perform next in my patient who's getting chest pain while walking? Well, is it going to be an adenosine nuclear perfusion stress test? Maybe. How about going to a coronary angiography? Isn't that a little too aggressive? They're going right to the cath lab. Should we do just an echo? I mean, don't get me wrong. You say chest pain, you're probably going to get an echo somewhere, but is that really going to tell you the etiology of the chest pain, just getting an echo? I'm not feeling that. How about an exercise stress test? You know, that sounds pretty tempting. So what's the bottom line point of this question is, are we going to do a chemical stress test, or are we going to make this patient exercise? And you know what? If you want to get the right answer on the board exams, the answer is, D as in dog. So let's have a quick shock talk from Dr. Raj. So anytime someone comes in and they say the word chest pain and you want to do a stress test, there are 2 main categories of stress tests. Number 1, exercise. Number 2, chemical. And on the board exams and in real practice, what is your default answer all the time? Exercise. Make them exercise. So when they exercise, you want to make sure they get their maximum predicted heart rate. So I know what you're thinking, Dr. Raj, what is my maximum predicted heart rate? Well, I'll tell you what, when I go to the gym and go on my elliptical, I always want to get 220 minus my age, 85% of that. So your patient needs to do that. That's their maximum predicted heart rate. If they can't do that, chemical stress test, they can't exercise. So now that they're exercising, let me just say this now. Everyone always thinks when you exercise, you got to be running like this, and that's not the answer. We do it on the bicycle sometimes. Sometimes we'll do a little psychoergometry with the hands. So once you exercise, we got to see, are you getting damage in the heart? So what can we combine with the exercise? 3 main things. Number 1, EKG. Number 2, echo. Number 3, some kind of nuclear imaging. So which one do I pick for boards on my patient? Default answer for the board exams is always exercise EKG. I hate to say it, it's cheap. It'll make insurance companies happy, and that's why you got to order this. But when can't you order an EKG is if they have baseline abnormalities. Anytime there's abnormalities with the EKG, you can't combine it with an EKG because what are you looking for? EKG changes. Number 2, what about the echo? When can't you do an echo? Well, how about, you're exercising, you have to lay down, you have to put the wand on you. Maybe your body habitus isn't conducive to an easy echo. So your BMI, your body mass index, your body habitus really influences who would be good for doing an echo. And last is going to be a nuclear study. And I got to tell you, nuclear studies are the Cadillac of studies, They're good because they're very prognostic. They tell you about prognosis, but very time consuming and very expensive. So now that you know that your patient is not going to exercise, you got to do a chemical. And when you want to do a chemical stress test, what are the main stressing agents that we have? I put the big 3 from board exam land, which is going to be dobutamine, adenosine, and dipyridamole. So dobutamine, remember, it's a beta-1 agonist. And when would I not give dobutamine? if a patient has tachycardia and arrhythmias. Doesn't seem like a good idea. And let me combine adenosine and dipyridamole. When would I not use these combined drugs? Well, you know what? One of their side effects is bronchospasm for both. So if someone's actively wheezing, like an asthmatic or COPD, may not be a good choice. And by the way, how do both adenosine and dipyridamole stress the heart? Oh, that's right. They're vasodilators what? Dilators. And so they induce what's called a coronary steal syndrome. That was a USMLE Pearl. So remember that. So now that you chose, based on the side effect profile, what chemical you want to give, then you had to combine it with a imaging or stressing modality. And what a surprise, it's the same things we use for the exercise. So you can combine chemical with EKG, chemical with echo, or with nuclear. And you know what? I put a couple extra arrows there in my diagram because in some of the university settings, we could do a stress MRI and we even do stress PET CT scans. Can you believe that? I don't believe it. So remember, the first decision is, can they exercise or not? So let's take this knowledge, and I'm in a nice mood, so let me give you a couple of extra questions. How about this 60-year-old guy comes in with chest pain? The pain he reports on the left side is a burning quality, non-radiating, sometimes with activity, resolves with rest. It's been going on intermittently for 4 months, and after eating dinner. Why did Dr. Raj put that? This is not pain on exertion now, this is pain at rest. Red flag, needs to be worked up. Other than occasional chest pain with exertion, he can walk without limitations. Has hypertension, big fan of hydrochlorothiazide. On exam, afebrile, normal tensive, non-tachy, non-tachypnic. And they do an EKG, which you should. It's chest pain. And it shows that there's some non-specific 1 millimeter ST segment changes in the anterior and lateral leads. It has changes consistent with atrial enlargement and left ventricular hypertrophy. Which of the following is the appropriate diagnostic test to perform next? So let's go over these together. Is it going to be a calcium coronary artery score? I didn't even mention that, but I'll tell you what it is. This is a test that you do as a prediction test. What is your chances of developing heart disease in the future? It's done in asymptomatic patients with intermediate risk for heart disease. And I'll tell you one thing, this patient is what? Symptomatic, so it's not going to be A. Is this person someone who could exercise or not? And the answer is, oh yeah, patient can definitely 100% exercise. I love it. So already when I think of the word pharmacological stress, there's no need to push the drugs on this patient. So now it comes down to B and C. And which one do you think is going to be the right thing? He's going to exercise combined with what? Oh, you guys are so smart. I don't even need to be here. The answer is what? C. Why isn't it B? For one reason. He had baseline EKG changes. And because of that, you can't use EKG. So of those choices, it should be an exercise nuclear. And look at the little pictures I put for you. That is what a nuclear test looks like. On the resting, look at all the uptake of the dye, looking nice. You stress the patient and the dye doesn't get taken up. That's a red flag. So usually I say goodbye at this time. But once again, I'm in a generous mood. Third question on this video, I'm taking it up a notch. So 74-year-old woman is evaluated for a 3-week history of left shoulder pain, dyspnea on exertion, history of COPD, smoker, hypertension, and coronary artery disease. She had stents that was placed in the LAD 3 years ago. Because of her lung disease, she has limited exercise ability, limited. She's on ACE inhibitors, hydrochlorothiazide, a statin, aspirin, fluticasone, albuterol, and ipratropium. On exam, those vitals look great. BMI is 29. Her central venous pressure, CVP, is 8. Cardiac exam reveals a 2 out of 6 mid-systolic murmur, heard best at the cardiac base, and some late expiratory wheezing bilaterally. And note, it's in red and bolded. EKG shows some left ventricular hypertrophy. Which of the following is the most appropriate diagnostic test to perform next? So let's look at this together. Well, B, going right to the cath lab. Once again, really invasive for the board exams. I'm not saying this patient's not going to end up there, but I think to do it next is going to be a little bit on the aggressive side. So look at choices A, C, and D. They're all stress test choices. So what was Dr. Raj's algorithm? Can the patient exercise or not? And the answer is no. She's very limited based upon what? Her COPD. So she needs what? chemical stress test. So I look at those two choices, and I say that A and B are the only ones left. So if I'm going to give her the chemicals, what would you give her in someone with COPD that's actively wheezing? You guys listened. You guys are amazing. The answer has to be what? C. Because what does adenosine do? What does dipyridamole do? It causes what? Bronchospasm. So I gave you 3 of the most common questions seen on board exams. If you want more questions like this, check out my book, Medicine Morning Report, Beyond the Pearls. You can get that on Amazon. You can get that at the Elsevier website. I'm Dr. Raj, educating you today for a better outcome tomorrow.